Welcome to Open Source Health. I'm Tripp Johnson, founder and social entrepreneur who spent the last decade trying to make healthcare a little more humane and accessible and a lot less soul-crushing. This show is about the real work of changing a broken system, from policy and strategy to using technology and AI in ways that actually help people. Whether it's intake forms, care teams, or back-end systems, we're digging into how healthcare can be built for real-world impact. Glad you're here. Ever feel like your brain is juggling swords while riding a unicycle? Welcome to the club. Today we're diving into the ADHD diagnosis surge, what's fueling it, and what it says about our society. Buckle up. It's going to be a thought-provoking ride.
Hey. Manic.
I'd like to call it hyper-focus in light of today's discussion around the New York Times article on ADHD.
Yeah, it's a nice segue. How's the weekend?
It was good. You know, the in-laws were in town, which is always a lot going on. It's wonderful to have extra hands, and couldn't ask for better in-laws, and it's nice to have my space back.
Yeah. That was super
Multiple things can be true at once.
Yeah, that's a good segue too.
Shout out Bill and Lynn. What up?
That's so good. Oh, man. Right on.
How about you? Good weekend?
Yeah, man, it was good. It was beautiful weather. Got to I can definitely tell I'm getting older because like the flow of my weekends is like funny, like the stuff that I look forward to. I planted grass last weekend, and so this weekend it was supposed to start germinating, and then I saw it popping up, so that was exciting. And then got in and had some good jujitsu time, and it was nice. I was the only upper belt on the mat, so that meant that I got to dictate the terms and control the pace and not get pushed too hard and have a good time. And then cooked some. There's this dish from Chai Pani that I'm obsessed with right now and have been for a long time. It's this their version of a sloppy Joe with lamb, and so I've been playing with that for months, trying to tweak it in. I think I came relatively close. So, a good weekend.
So just before moving on, I want to confirm that I heard something correctly. You now watch the grass grow.
I now watch the grass grow excitedly. Okay. Yeah.
All right. I don't know where to take that, but I'm sure it's going to pop up again later. So why don't we try and get into the most recent, big piece that came out from the New York Times?
Yeah, I was so Nick, kind of our executive or COO, sent it around, and I think it made its rounds. But I was really interested in it because I think it pertains to a lot of my skepticisms about the mental health field. But essentially, the gist was that there's been this huge jump and increase in ADHD diagnosis and correspondingly like stimulant prescriptions and all this sort of stuff, right? And the general idea was that essentially ADHD is almost like a astrology, right? Like it's like reading your astrological sign to some degree, right? There's a lot of room for subjective interpretation from both the identified patient and the provider, and so that makes it a notoriously easy to misdiagnose or overexpand the diagnosis. And then you create the incentive structure around, people want their little buzz, they want their stimulants. So that makes it really easy for to see this big explosion in ADHD diagnosis. But was there anything in there that was like particularly captivating or interesting?
If you don't remember, I told you I skimmed it. I just completely no. The short answer is no. I did not read the article in depth. I think there's a lot of confirmation bias for me in terms of I'm actually more familiar with this in terms of autism, or at least the skyrocketing diagnoses around autism. And I think one of the first questions is, are we just detecting it better? Or is there been some sort of shift in society that is making these actually statistically more prevalent in the past? Yeah, I think especially when it comes to autism, a lot of it is probably better diagnostics. I think like for so long, women weren't diagnosed with autism. It just presents differently. And so I think like when we talk about uh, maybe the blanket term being neurodivergence, and because I usually try and get out of things at home where I try and use my neurodivergence as an excuse for why I cannot do basic tasks.
Yeah.
But I think that spectrum of neurodivergence is pretty broad. So I find the whole idea of, diagnosing people kind of interesting. I think you and I, there may be an article we can drop in around like the what is considered a transdiagnostic approach to mental health, and why that maps on really well with my understanding of the world, but does not really map onto how we bill insurance and create treatment plans and everything else.
Yeah. I mean, I think both of us come from a non-dualistic perspective, right? Where we recognize and experience the idea of self as an idea, this ever flowing, changing sensory experience sort of thing. And I think once I started having that sort of enlightenment moment, it's really difficult for me as a therapist or someone that's been involved in mental health to wrap my head around the concept of diagnosis, and then also seeing sort of the trappings and the dangers of it. I don't think mental health is seeing a therapist or seeing a provider is this totally benign thing free of risk, especially when it comes to diagnosis.
Yeah, I mean, because from that, maybe I'll try and define non-dualism, and you might have to help me out here. But I prefer to use the word contemplative rather than spiritual for less maybe baggage for some people. But I think both philosophically and scientifically, the concept of self is often misunderstood. By the general public, like we have this experience of being a discrete entity in the world who's navigating life, and usually it takes a lot of training, meditation, really good pointers from teachers, some sort of work to dispel that notion. Even years and years of meditation, you can sit there and be the meditator meditating if you don't have the right instructions.
Yeah.
And so when it comes from that worldview, it becomes very difficult to ascribe right and wrong, good and bad, right? Because it's just changing experience that is happening.
Right.
But when it gets into diagnosis, it's like, well, we have to diagnose, or someone's complaining of a problem and we need to correctly identify the problem.
Right.
And oftentimes, like the diagnosis, the problem is like we're not living the way society thinks we should, or we're not functioning within the norms of society, or we're not getting what we want out of our experience. And so for me, that's kind of a helpful place to start. Is the goal of any mental health journey or self-improvement journey, contemplative journey, is that, we're kind of saying, hey, we're experiencing the world in one way and we want to experience it differently.
Yes.
And how does that intersect in your mind to kind of the diagnostic component of mental health treatment?
Oh, man, that's a fascinating question.
Sorry. We might just hold up a finger if you need me to keep ranting about something. I'm well caffeinated.
You could just, man, you could have just asked me what the weather was today or something. Fuck, man, that's an interesting question, right? So I think of this in very practical terms, right? Like we've talked about this idea of enlightenment, and not everybody's going to indulge or get engaged in the process of sitting and practicing meditation. Like that's not what they're going to do. That's not what they're interested in. Um, and so, like talking or preaching this sort of idea of non-dualism or getting rid of this concept of self, like it's just a non-starter for most people, right? Like most people aren't interested in that. It's weird. It can be destabilizing for some people. It's just not a viable thing that's practically going to happen, right? And so, yes, that may be the best path for each individual towards lowering their spirit, the amount of suffering that they have. Right? You can suffer less by going on this contemplative path, but most people aren't. So then it becomes a maybe more of a utilitarian question. Well, how do we reduce suffering, right? And if that's mental health, the mental health treatment is arguably that's its primary function is reducing suffering, right? Like that's what it's getting at. So then I think diagnosis and that sort of stuff potentially becomes useful and important because it gives someone language through which they can begin to conceptualize interventions that they can leverage, do, and engage in. Um, so that would be my initial like shotgun attempt at answering it.
Yeah. Well, let's
Yeah.
bring it down from trying to incorporate and explain non-dualism and diagnosis, which in some ways is a paradox in and of itself. If you go down that rabbit hole, but let's just talk about let's start with substance use disorder and then move to ADHD because I think we each have good experience to leverage on both of these. And both of us have been somewhat skeptical of the over pathologizing originally of substance use disorders, but then moving into ADHD. And I want to maybe you could just speak to some of the families you've talked to and worked with over the years, and maybe or say I'm a parent calling and I've got a 20-year-old kid who's in college and he failed a class
Yeah.
and got a drinking ticket, and what you might do to help them assess whether or not this was a severe substance use disorder or kids being kids.
Right. So I mean, I think the first thing is gathering a history, right? Like, and this is where it's always difficult because the history is coming from the patient. They're going to have some biases and some slanting involved in that. Then it'll come from the family, and then but you're trying to get this comprehensive picture of maybe what's actually going on, right? And so usually
Could
my
you could you spell out like a biopsychosocial and just kind of explain that comprehensive picture?
Yeah, so biopsychosocial is essentially asking biological questions like heart rate, like health history, all that sort of stuff, right? It's just trying to get a general sense of what the biology is, how much you're drinking, how often, what substances, and any of those things are right. But the idea is you're just generally trying to get a sense of the biology of the person. And then the psycho is what are they struggling with? What are they suffering with? What is their experience with the world and what is the thing that's leading them to seek treatment. And then the social is like how does that stuff start to impact them in their social relationships, right? So what is what's the total picture of how their experience in the world is impacted through their biology, their psychology, and then their social, and how's that manifesting in social relationships.
So maybe let's stay away from actually giving any sort of mental health guidance, right? Talk to your doctor or therapist about this, not us. We may not be well regulated as it is. But like from a practical perspective, like what are some of the, guidelines you think of? Because you and I talk about this a lot. Just like,
Yeah.
point out a couple scenarios for us on the substance use side.
Yeah. So, I mean, what I'm looking for, and I think what's important is like, is this creating pretty serious impairment in someone's life, right? Is this an actual problem or is this a one off? Like, we can all have a bad day. We can all do whatever. Anybody that uses substances is going to have some point at which they use more substances than they wish, you know, and then made a plea to the gods to get them out of whatever, the morning after experience, and they'll never do it again, right? So like I think most people could use substances and probably fall into, some of the diagnostic criteria without actually it being relevant or that important. So one of the first things I start to look for is like what's the level of impairment and like throughout their quality of life in a lot of different domains, right? And so I think that becomes a very important framing. Um, Oftentimes I'll have a family will call and I'll be talking and what it turns into is like the mom or the dad or someone, you know, they're seeing a guy flounder for some reason, or they're seeing a child flounder, and then they're looking and they're thinking in terms of like their their pot use or something like that, and then they want to seek treatment or do something like that, and it's like, well, there may just be other stuff going on that then the pod is THC is just the thing that you're hanging your hat on or something, right? It's the most obvious thing to ascribe blame to.
I think we should. You know what we'll do? So we have an actual expert come. I think we should get Shane to come and talk about substance use disorder diagnosis, especially as it pertains to adolescents and young adults. Because I think that's been one of the places you and I are real prickly around is before someone's brain is developed, it really becomes, I think, hard to separate what is that undeveloped prefrontal cortex and impulse control and, normal kids being kids kind of behavior from, the early signs or, later signs of actual severe chemical dependency.
Yeah.
Note to self.
Note to self. Yeah. And I think I think it's interesting, right? Because when you are, especially in substance use treatment, you're sort of inviting someone into adopting a new identity in some sort of capacity, right? And especially in abstinence-based treatment, you're essentially asking them to adopt the identity of a person that's in recovery. And I've seen the work well for a lot of people, and I've seen it. It's not a totally benign thing, right? Like I talked to a family a couple months ago that their son was primarily just using pot, and they wanted to get him into some sort of treatment, and it sounded like there's a lot of other stuff going on completely unrelated to that. And it's like, well, why don't we just start with therapy and stuff before we adopt this identity of person in recovery?
One of the paradigms you pointed me on to early was the idea of not poisoning the well. And I think this is especially important when it comes to substance use in young adults. Because I know from my personal experience, parents can overreact big time about a one-off, even though, and it can also become a really big problem in the future. And so I think in relationships and for parents, a lot of times the idea around treatment, one of the things we need to be aware of is not poisoning the well, meaning that we don't want someone to take an overly restrictive step that causes future pain and maybe prevents them from entering recovery or getting the help they need. And I think that's one of the things we try and bring into a lot of our clinical work, but also just how we engage, families is the idea of, hey, for that guy who's, maybe smoking pot and seems like he's having a little failure to launch, we don't need to jump straight to residential treatment necessarily or something like that. But if we try an intervention at the outpatient level and it's not working, we're kind of building the evidence to say this is a consistent, persistent issue. And then it becomes a lot easier conversation to say, hey, we tried all of these steps. Now we're going to need something more restrictive to get things on track. And if you go straight to a 16-year-old who gets caught drinking for the first time and sending them to treatment, then that person by 17 or 18 may have developed a very serious drinking or drug problem, but they've already poisoned the well, which has made them treatment resistant, even though now they actually need treatment. So you don't want to go at, I don't know my cancer analogy, but you don't want to go on the, crazy chemotherapy about something you can just cut out real quickly.
Right.
And I think the same it can be true for these mental health interventions, but it's all more abstract. So it's harder for families to wrap their head around. And then you compound that by the fentanyl crisis or drinking and driving. And one big mistake that is not substance use disorder can completely derail a life.
Yeah. I think this is actually, you brought up something interesting there too, right? Like there's this idea that at least with substance use, you can kind of put your finger on it, right? Like you can see it. The rest of mental health, a lot of times it becomes more difficult to really put your finger on what is the disruption, right? Like, if someone's got catatonic depression, that's a really clear, and you can see it. It's in the consequences of that are really present. But what about someone that's just mild depression, like moderate depression, or just this sort of like depression that mutes their overall experience, right? Like that's the sort of stuff that I find a little interesting. And in this past week, you have really started the work of like outlining our treatment philosophy and how we think about things, and you're really hot on this idea of uh, least restrictive, least intense level of care relative to this, like what's being presented at any given moment. Is there a particular reason you're really hot on that right now, or like what was there a clarifying thing that like really just pushed you into that to think about it?
Yeah, so I mean, I think we're just at a stage in the organization where we can keep building and growing, and likely that's kind of what most organizations do. Or we can take this as a really intentional time to slow down, make sure that the foundation is totally set throughout the organization. And so for me, a lot of this starts at the more kind of corporate theory level about how do you run a good organization? What's your vision? What are your values? Um, all of that kind of work. But ultimately, this is intertwined with what we actually do. And we wanted to, working here, we want it to feel like a consistent experience. And we want you to go out in the world in a certain way to help accomplish our vision. So in terms of, I guess I'll start with mission, and we made it super simple when we redefined this, and it's just to move people from suffering to flourishing.
Right.
And we started with that because it seems like the one thing we could probably all agree on, coming from different types of practice, is like that is our job in healthcare, is to alleviate suffering and promote flourishing.
Right.
And that framing of it got us out of some substance use paradigm where it was MAT versus abstinence based or whatever you want to have there. So that's kind of like where we started. And then I had a lot of internal conflict around this idea of coming up with like patient care guidelines, because I'm not a trained therapist, provider of any type. And so who am I to say what patient care is supposed to look like?
Yeah.
But then on the other hand, it's like, well, if you were the person who spent a lot of time recruiting your top clinician, your top, medical provider, et cetera, then you're trying to get people who are going to practice a certain way or who want to achieve the vision that you all are sharing.
Yes.
And so I've become very interested in this because I feel like I've seen over time that whatever training people get in schools doesn't necessarily set them up for success in an organization. And quite frankly, a lot of, you can have great training and approach things differently. I'm not saying there's our way is right and other people's is wrong, but there is a way we do things. And there is a way that, that we want to do patient care. And the way that we want to do patient care affects everything else we do. So I'm really hot on this idea of us having articulated, I'll probably post it by the time this podcast is out, but our approach, the Advita Health approach to patient care. And the idea being that this tells our top clinicians and medical providers, this is generally how we're approaching treatment. And we want you to use all of your discretion within certain guardrails, but we don't want you to work here if you think that, substance use disorder is a moral failing.
Right. Right.
Similarly, there are a lot of places that do 5, 10, 15-minute med management appointments. And that's fine if someone just wants their script, right? And they may be totally fine just getting there. Just it's kind of like birth control. Hey, I just got to come back for my birth control every 6 months or a year. That's not the way we're approaching mental health, because that's not our view on like the subjective experience and how people change over time. So I think it's just really important to say, hey, like we're not the Adderall on demand ADHD treatment company. They exist.
Yeah.
And they're
Yeah.
out there, and you can go to them.
Yeah.
But for us, we're going to follow a certain diagnostic protocol. We're going to follow certain general guidelines for treatment in order to get us to, the best recommendations for treatment for that patient at that time, because it allows us to move in a more linear fashion over the course of treatment.
Say more about that last part.
Yeah. So, I think it's, again, I know we were going to talk about ADHD, but for my analogies are all coming from the substance use side. Um, let's just take a junior at NC State gets a DUI, and they're in a fraternity. This is the first time they've had an issue with drinking, and they come in for a biopsychosocial, and turns out they meet a ton of criteria for substance use disorder, right? And one option is, hey, like, look, you statistically from the assessment, you qualify for residential treatment or partial hospitalization, but it doesn't feel right. Like sometimes you get those where it's like, yeah, I mean, don't you know how to lie on this? I didn't think you wanted to go to treatment.
Those are always fun.
But it's like, wait a second, like you are actually doing everything in a very normal way. Now, that's not to say that normal is good. But this is all very age stage appropriate, what we expect from whatever Pike Kappa Epsilon, Theta at NC State. Like we expect that you're drinking heavy 4 nights a week, dabbling in some cocaine. It's just, that is what it is. Most people outgrow that, right? So for us, like what I would want to do is I would want to say, hey, well, let's see if they can actually change some behaviors through individual therapy or therapy plus medication management. We may not be at a place where we want to use like anti craving medication yet, but hey, like if they're having some trouble with cravings, maybe it is. In terms of, I guess I'm going to try and shift gears here to the ADHD one. Like, how much is it getting in the way of your life, right? And so, how do we sequence an event so we may end up using more restrictive interventions over time, but then we may pull back some of that scaffolding? And if you're working exactly, and we talked about that expand and contract around, a recovery oriented system of care. And so I think it's really important, and we want long-term patients who are interested in this flourishing project, which means like we're not the North Raleigh pill dispensary where you call in and you say you got a flight and you come pick up your Xanax, and then you say, you got a lot of work and you need some Adderall. And I'm not even saying that that's wrong.
Right.
But I am saying like that's not how we're approaching patient care. And so it is much more longitudinal. It's understanding your history to know how we can actually be the most helpful now. And from a personal side, I think there are a lot of times where we accept the pain now for the deferred reward, right? Like we've talked about with whether it's working out, going to bed on time, things like that. It's not as fun now, but overall our happiness and our satisfaction with life is going to be greater. And so I think about our, patient provider relationship as one that should be utility maximizing. We want to be partners in your journey of flourishing, which doesn't mean that we're solving this immediate problem with the quick fix today. It means we may kind of, I don't want to say meander, but we'll walk alongside you so that we can expand and contract those interventions as necessary.
Yeah. I think that gets into, right, like to tie it back into some of the non-dualism stuff, right? Like that is the golden thread that we're sort of trying to run through the organization of like care delivery and patient acquisition and all that sort of stuff, is like how do you take this perspective that, hey, what we see in one given moment isn't exactly what we're going to see in the next moment and the next moment. And so you have to have a system that has the right sort of providers, the right sort of therapists, the other people that can hang with that ambiguity or hang with the idea that the patient I'm seeing today is not the patient I'll be seeing a week from now or a year from now or a month from now, and have this sort of long view. And so if the idea is like, hey, we're going to slap a diagnosis on it, we're going to tell you what's wrong, and then we're going to give you the med that makes that go away. One, I think that's misleading, right? Like, I don't think that's actually how that stuff ever ends up working. And two, it's just not what we're interested in or being about. because I don't, at the end of the day, it's probably not terribly effective. Uh, yeah, and that what to me was what was interesting about the ADHD stuff is it's like, yeah, listen, we're seeing an expanse of diagnosis. We're seeing more people getting prescribed stimulants, all this sort of stuff, but no one's like taking this contextual view of it, right? It's like, yeah, at any given moment, we've got 15 things pinging for our attention and vying for it. And so it's like, yeah, of course we have this sort of feeling, but that doesn't necessarily mean that there's a pathology. It just means that you may have to like reorganize your life in some sort of way.
Yeah, I think what I would connect that to as well is I think there's an increasing body of literature out there showing that our technology is shaping our brains. So yes, when we get you know we go down the social media rabbit hole and we're being fed by the TikTok and Instagram algorithms, we're naturally it's too easy to change the channel. You just keep swiping.
Uh-huh.
And so we're being trained to we either like something like at first glance we like it and we watch it, or we move on to the next thing. And this Scott Galloway quote is something like Paleolithic brains, medieval institutions, and godlike technology. And the technology is kind of overriding our quote normal brain function. So the question I would ask you is like kind of play out the ADHD and stimulant prescription maybe to a logical extreme,
Mhm.
and maybe make it seem like what's the problem with prescribing more stimulants?
Yeah. So, I mean, beyond the fact that it's potential habit forming has a lot of potential for abuse. Like, it's we're not probably not sure that it's actually that effective, right? Like, I mean, I think that was one of the interesting observations in the article was that stimulants are really good at making people feel like they're doing better. And so for me, it becomes a matter of, hey, what are we looking for practically? Because the thing is, do we want to do performative, like feel better, or do we actually want to do better? Right? Like I don't want to feel like I'm doing better. I want to actually just do better. And I think this goes back to what you sort of articulated long term is this idea of like, listen, go to the gym, you sleep, you do all this sort of stuff. Like your quality of life is just going to be better if you're doing the sort of things that make you, that lead you to feeling better versus like I'm bypassing all of that and I'm going to take a pill that just makes me feel better. Right. And so one of the things I think that the article sort of discusses that I find really interesting is this notion that when they would do these tests on people, like control trials for people on Adderall and people not on it, what they would find is like their actual output and performance like was the same. It's just the people on stimulants felt better about it. And so if you want to take this to its real logical extreme, it's that you never actually end up doing anything to manage your symptoms. Um, and I'm not an anti-med guy. I think I'm like super clear on all of that sort of stuff, but I am an effective med guy, right? And if the idea is that you're looking for a buzz, like well, you'll probably find that, but it's not actually categorically going to improve your output. And that's what I think kind of is more important.
Yeah, I'm going to take a pass at it and say
Yeah.
if stimulant medication helps people with ADHD, then just prescribe stimulants all day long.
Yeah. Yeah.
The thing is that, as you indicated, like we are creatures of habit and we develop a tolerance to anything. So then it's like at some point, you probably have to keep increasing the dosage over time. And at
Yeah.
some point, that may also have negative effects on your heart or other things.
Yeah.
I know I'm really excited to have Dr. Book on at some point and talk about this because he talks a lot about, what amphetamines do to someone, especially if you've got a substance use disorder. And like, for example, our prescribing habits for people who are in recovery from substance use disorders, like we're not going to prescribe rapid release,
Yeah.
amphetamines. We may prescribe extended release because you don't want to just flood the zone with dopamine and then crash.
Mhm.
Because both ADHD and substance use disorders are often characterized by a lack of impulse control, and they just want to keep that high running.
Yeah.
So I mean, I see that on one hand, like somewhat similar to, but I think these drugs can feel magical, right?
Yeah.
Like, I mean, again, you feel like you're more productive, and if your subjective experience is better, I mean, that's kind of a win in the flourishing camp.
Yeah.
But over the long term, you become habituated to it, and it may not deliver the desired effects, and then it becomes its own problem. And I think that's true of anything. Like, we could take the GLP-1 drugs, like, this may be awesome, but we probably still need to do those foundational activities of, meditation or mindfulness, exercise, diet, and sleep, not use the drug as a crutch to say we don't have to do those things. So I think, like what we've talked about with community, part of treatment should be getting you involved in a community, getting you involved in relationships. Part of treatment is also, helping you be equipped with the ability to manage your activities of daily living and take care of yourself on your own. And medication can be there as a tool. Therapy can be there as a tool and help you with perspective taking and everything else. But that, so much of what we do is actually geared towards how can you be independent, functioning at the highest level possible without assistance.
Yeah. That's the path to flourishing.
But it's tough. And then you got to figure out how to write copy on the internet, on our blog, and ads that we tell people we're not going to solve their problem in 15 minutes, whereas everyone else is going to tell you, hey, you just give us a call, we'll get you an appointment, and we'll have you on your way. Yeah. And that's tough. And I think it's actually one of the most interesting challenges we have organizationally is, how do we attract people who want to go on this flourishing journey alongside us versus look at us to give them the thing that's going to fix it? Because there isn't a thing that's going to fix it, because it doesn't exist. You are just a collection of experiences and sensations. And until you understand that, you're probably going to suffer more than you need to.
Exactly.
I don't know how that went. Yeah. Well, until next time. Thanks for tuning in and navigating these complex topics with us. Remember, understanding ourselves is a journey, not a destination. Stay curious, stay compassionate, and we'll catch you on the next episode.